Whether you're fighting, healing, caregiving, treating cancer, or simply searching for hope, this space is for you. Welcome to FU Cancer, where meaningful conversations meet powerful community. My name is Juliette Jorgensen. I'm your host, a registered dietitian and cancer advocate, and together we're turning challenges into connection. Check out our platform on the web at fucancer.health. Welcome, Dr. Matichak. We are so excited to have you here on the FU Cancer podcast.
Thanks for having me. I'm happy to be here.
Of course.
And you can please just call me Adam for the rest of this.
Okay, Adam. Well, Dr. Adam Matichak is an acute care in-hospital physical therapist and board-certified clinical specialist in oncologic physical therapy at Stanford Health Care, working with hematology, oncology, and stem cell transplantation populations. He regularly presents in oncology rehabilitation, immunotherapy, and communication skills in complex medical settings. Dr. Matichak has presented nationally to the American Physical Therapy Association Combined Sections Meeting and the Cancer Rehabilitation Community Conference. His work focuses on advancing patient-centered oncology rehabilitation through education, research, and mentorship. Wow. We are so honored to have you. Thank you so much for joining us.
Absolutely.
Wonderful. Okay, well, let's kick it off with some questions, Adam. Out of all the different areas you could have specialized in, which are a lot, what drew you specifically to the cancer continuum and hematology, oncology, and stem cell transplantation in particular?
Yeah, so I actually lucked into working with cancer patients. Just kind of stumbled into it. My last clinical rotation of PT school was at Stanford. And basically what happens with our student program at Stanford is you just get assigned to a clinical instructor and you just work on whatever units the clinical instructor works on. So I just happened to be, there wasn't something I was seeking out. I just happened to be assigned to a clinical instructor that worked on our hematology and bone marrow transplant units. And so going through PT school, I was total ortho bro, thought I was going to work in outpatient orthopedics and sports. And, I worked in the hospital on a, 12-week rotation and absolutely fell in love with it. It was one of those things talk about really having a meaningful educational experience and, talking with classmates that are going through rotations and, having been through several outpatient rotations myself, it's great being able to get that weekend where you're back to, playing golf or pickleball or whatever it is, that they enjoy doing. But working with someone that's going through the lows of a cancer diagnosis, and specifically these patients with, lymphomas and acute leukemia that are going through, multiple rounds of chemo and stem cell transplant, and really getting them back to just a point where, they can start feeling like themselves again, was just such an eye-opening experience for me. And so ended up working in an outpatient clinic for about 6 months after I graduated from PT school. And then they had a change in leadership and a spot opened on the BMT team at Stanford. And I've been back there since June of 2016. So just finished 10 years there at Stanford.
Wow. Congratulations, first of all. What an accomplishment. And yeah, it's so interesting how life works and you think you're going to go the ortho bro route and then you do something completely different. So, but I'm happy you ended up here. I know you've changed so many patients' lives and I'm excited to see what else you do. So as an individual who works with patients during some of the most heavy moments of their lives, what have your patients taught you about resilience, vulnerability, and emotional strength?
I think the biggest thing is it's not an all or nothing thing, right? We have patients that, talk about resilience, and it doesn't have to be this overwhelming show of strength. Sometimes resilience is, having that vulnerability to say, I'm scared or, I'm worried about how this is going to turn out. And really just kind of, understanding that it's a big spectrum of emotion, right? And we have to be able to deal with all of it, right? Because our patients, they're going to be afraid. They're going to be grieving the loss of the person that they were before their cancer diagnosis. But then we get, these patients that are going through treatment and, they're seeing, positive scans and good test results, and they say their blood counts coming back, and it gives them hope and this sense of self back. And so it's this huge spectrum. And so being able to like not pigeonhole patients into like, this like, right, we've always had that like, warrior mentality when patients going through, any kind of cancer diagnosis, like, fight on, and, you have the strength to do this. And, it's really taking that step back and meeting the patient where they are and realizing that that patient is a human being, and humans are overly complex emotional people, and individuals, and really being able to kind of identify, what those patients' strengths are, what their weaknesses are, emotional from an emotional standpoint, be able to, like you say, kind of meet them where they are and recognize those things to be able to work with them effectively. So if we try to approach every situation the same, right, it's going to land for half of our patients and it's going to fall completely flat for a lot of our patients. Being
Yeah.
able to adjust on the fly and kind of understand that, their emotions can, and especially the fact that their emotions can change throughout that continuum and throughout their cancer journey. So being able
Mhm.
to adapt and, uh, kind of have a better understanding of people.
Yeah, absolutely. That kind of leads into my next question for you. Of You're describing, I think, emotional intelligence, right? So, how do you define emotional intelligence and why is it especially important during a cancer journey?
Yeah. For me, emotional intelligence is kind of being able to recognize the emotions that our patients are showing, but then being able to
Mm.
recognize our own emotions as well. I think a lot of clinicians, especially as you get, years under your belt working with this patient population, you're going to come across patients that remind you of a former patient, or you're going to come across, I'm starting to get to that point where, I'm in my mid to late 30s. I have a couple of kids at home. And so when I walk into a patient's room and, they're a young dad and they have kids, I start to think about, what would I be going through if I was in that situation? And so
Yeah.
it's being able to recognize a patient's emotions, your own emotions, and how to regulate those things so that they don't kind of, especially for me as a physical therapist, like I don't want that taking over my session, right?
Mhm.
I don't want to be too guarded because, I had a patient, with this condition before that was going through this same treatment and they didn't make it. You start to get those thoughts kind of bubbling up during your session. Was it something that I did? Did I not push them hard enough? Did I push too hard? And you can become dysregulated very quickly if you're not in tune with those things and kind of able to manage those as you're working through a session with a patient, or as you're working with a patient over multiple sessions as they kind of go through their continuum of care.
Yeah. Yeah, I love that. Just it's a good constant reminder for us clinicians to meet patients where they are and to acknowledge that every patient is different, even if they remind us of a patient we've had before, but every patient is their own, has their own journey. That's super important to remember. So, kind of switching gears to look from a patient lens, cancer diagnosis, as we know, can bring fear, uncertainty, information overload, so many things, right? From your perspective, how can patients use emotional intelligence to advocate for themselves and communicate their needs throughout treatment?
Yeah, I think the big thing for patients is, right, we talked about that being able to regulate your own emotions. Because, when a patient, especially a newly diagnosed cancer patient, when they're sitting in that first clinical appointment with their doctor and they're just getting all of this information thrown at them, this is what your disease is. These are the genetic mutations. These are the, percent survival rates. These are the different treatment options you have. It's so much information overload that, and we kind of force patients to, especially with, my specific patient populations are like it's our acute leukemia patients, like that train starts moving so fast, that patients are expected to make these decisions about their care when they haven't had a moment to like stop and let it sink in that this is their new reality. And so being able to self-regulate in those moments and kind of slow things down a little bit. And I think this just comes with time for them, meeting with the doctors and going through treatment and being able to, slow things down to the point where they know what questions to ask. And then really the big thing is being vulnerable enough to stop and say, I need help, or, I'm not like, I need a day to sit on this before I make a decision about what's next. Becomes really important when we get to like that palliative end of life, hospice versus comfort care situation where, we're throwing all this information at patients. We're telling them that we don't have any further treatment options for them. And we're expecting them to make decisions about, well, what's important to you. And it's like, give them some time to, think about where they're at and what they've gone through and kind of what's next. And really just kind of have a moment to sit with things and not feel like they're being, not pressured, but, kind of forced to work through those stages faster than we normally would expect someone to. I think it's really hard for patients because they want to put on a brave face for their family or their caregiver, but it's really hard for patients to say, that I'm scared or I'm, fearful about how this is going to turn out, or, I'm scared of what's next. And being able to, as a provider, to sit with those patients and just be a human being and sit with that human being across from you and, kind of demonstrate that, I'm here for you. Like we can, especially from the rehab side, like we don't have to have a grand plan, but what's something that we can accomplish today that you'll be happy about? So it's really, patients being able to self-regulate and break things down into more digestible chunks and being able to like effectively get their needs across without feeling like they're being pressured into kind of making decisions, answering questions, feeling like they have everything figured out.
Yeah, absolutely. Thank you for breaking that down so well and just kind of giving a clinician perspective as well on how, how can we hold space as clinicians and just be human, right? So it can be so easy to just turn on clinician mode and try and, give clinical answers, but sometimes a patient needs a human, right?
Yeah. And,
So,
and that's years of practice and that's
yeah.
years of, saying the wrong thing or,
Mhm.
not, giving that patient the space to express their fear. And we did a talk at our national PT conference in 2025 called Watch Your Mouth. And it was all
Mhm.
about just like improving therapeutic alliance through effective communication. And one of the things that we learned through the research was that providers are really quick to either jump in or redirect a patient, even their first encounter meeting a new patient. Something ridiculous like a median time of cutting a patient off of like 23 seconds or interrupting a patient 6 times a minute when they're trying to talk. And so when
Mhm.
we don't give patients that time and space to kind of process the information that we're telling them and then give them the time and space to, formulate a response to us, one of the things that it does is it creates a lot of distrust for
Mhm.
patients. It makes them, they don't feel seen, they don't feel heard, they feel like every interaction with the healthcare team or with the medical system as a whole is the same thing over and over again. We just
Yeah.
don't build that rapport.
Yeah, that's a great point. I think another thing we as clinicians deal with, unfortunately, is compassion fatigue and burnout, right? So, how can clinicians develop emotional intelligence, what we've been discussing, but also protecting their own mental and emotional well-being?
Yeah, I think the first thing that you need to do is you need to recognize when those things are starting to weigh on you too much. Are
Mhm.
you becoming more irritable at work? Are you, becoming numb to those situations? Are you getting to a point where you're avoiding certain patients' rooms or certain units in the hospital? And so I think, the first thing is, that pattern recognition. And then the hardest part is asking for help, right? It's,
Yeah.
as a rehab clinician, it's going to my manager and saying, hey, like, it's been really heavy on the unit lately. I need a break. I need to float to another unit for a couple of days or a couple of weeks to kind of help me reset. It's having those healthy, self-care things outside of work. It's reconnecting with, family or friends or having a hobby that you enjoy, getting outside for a walk in the middle of the day,
Mhm.
really making sure that you're taking the time to take care of yourself. We hear that quote all the time that you can't pour from an empty cup, right?
Yeah.
And it's that like age old self care motto, but self care, it's not performative, right? Like
Mhm.
we have to, if we don't take care of ourselves, this job will destroy us. Like
Yeah.
the emotional burden of what we carry as cancer providers is a
Mhm.
lot day to day. And so we need to do things for ourselves that are making sure that, we're self-regulating and that we're not letting these things just fester. And
Hmm.
so having that person at work that you know is your go-to, when a patient passes, you know that they're going to drop by your office and check on you, make sure that you're doing okay. So having that kind of accountability buddy at work that is checking in on you, having those self-care rituals that, give your nervous system that chance to, bring yourself some closure and allow you to kind of move on from those really heavy things.
Yeah. Yeah, that's so true. I love that you're going to quote you that self-care isn't performative. It's so important to remember. Yeah. Circling back, just a couple more questions. Circling back to, we were talking about trust a few moments ago. So we know that it's the foundation of patient-centered care. From both the patient and the clinician perspectives, what are some practical ways to really build trust, especially when conversations do involve uncertainty and really difficult news or differing expectations?
Yeah. From a clinician standpoint, it's, being honest with your patient. It's taking the time to, I'm a big guy. I'm over 6 feet tall. I was a football player. So if I stand at the end of a patient's bed and cast them in shadow and like try to fire questions at them, like they're going to
Yeah.
be really uncomfortable. They're not going to like that situation. So, it starts with those nonverbal cues, right? Am I pulling up a chair and sitting down at the patient's bedside so I can be eye to eye with that patient?
Hmm.
Am I actively listening? Am I trying to chart and write notes at the same time that I'm asking these patients these really difficult questions? Or am I taking the time to sit and make eye contact with them and let them know that I'm listening to them and making sure that their needs are being met? And it starts there. And then it's the work that we put in building rapport with those patients over time, that they know that we have their best interest at heart, that, they're not just another checkbox on our schedule of someone that we needed to stop by and see today, that we care about them and that we're here for them. And it takes time to build that rapport with patients. And so I think every interaction is an opportunity to kind of build that trust and build that rapport. I'll own this one. I had a patient when I was a new oncology clinician. I had a young female patient, early 20s. She was eval on my list for the day. She was admitted to the hospital the day before. She had providers in and out of her room all morning. She was emotional because she had made the decision the day before to finally shave her head. Her hair had been falling out in clumps because of the treatment that she was going through. And I walk into that patient's room and I say, "Hey, I know there have been, other providers in and out of your room all morning. My name's Adam. I'm a physical therapist. I just have a couple of questions for you and then I'll get out of your hair." And she immediately burst into tears. And so, right, we talk about building trust with our patients. And I had to, I removed myself from that situation, but I went back later that day and I owned that mistake that I made, because it's just words, but that was
Hmm.
really meaningful for her. And so being able to go back and own that situation, I made a mistake. I still feel like I'm one of the best providers that can provide care for you in this situation. But if you'd prefer to work with somebody else, let me know. Owning the mistakes that we make, especially when it comes to communication with patients. I didn't like the way that what I said came off, or, I just want to clarify, something that I said earlier, or, even asking for that patient's understanding of something that you said, so that we make sure that, that communication is both ways, that we're understanding each other, so that we don't run into those situations where the patient feels like we're providing false hope. Because I think that's the biggest thing in cancer care, is that, we go down those rabbit holes where patients just keep getting fed, this false hope that, we know this one didn't work, but we have another treatment we can try. Or when we're working with patients from the PT side that are clearly disease progression, not responding to treatment. Their counts are all over the place. They're on a bunch of steroids that are making them weaker. And we just say, "Oh, maybe you'll be stronger next time," or "this will get easier." And so that's not always the case. And so being
Yeah.
able to sit with that patient and say, "This isn't heading in a great direction for you functionally. But what are little things that we can work on that are still going to be meaningful for you? How do we continue to move forward in those hard times?" We need to make, like, if we don't have that rapport and that trust with our patients, they're not going to really buy what we're selling, right?
Yeah, absolutely. Gosh, thank you. That was such a great comprehensive answer. And thank you for giving us an example too. I know you're not alone in that. I share similar mistakes as a clinician and regrets, but I think you handled that beautifully and just, you know, you're human and going back and saying, how can we make this right? And that's great. It's a great reminder for all of us clinicians. So thank you. And we just have one final question this evening. If you could leave both patients and healthcare providers with one piece of advice about bringing more humanity, connection, and emotional intelligence into every encounter in oncology, what would it be?
I think one of the biggest things is not to like rush through the emotional part of it.
Mm,
From a clinician standpoint, it's not our job to like shuttle patients through the stages of grief so that we can get them to a point where we can work with them. It's
yeah.
meeting that patient where they're at and really having a better understanding of who they are and what their goals are, their fears, their hopes. The more that we can kind of boil things down to that point where now we have a better understanding of this human being sitting in front of us and kind of what motivates them, what things they're anxious or nervous about, we're going to be able to provide a much higher level of care. And over the years, what I've seen from the patient side is, to let yourself be vulnerable. I think, the patients that do the best are typically the ones that have the biggest support system, family, friends, community, church community, the patients that are able to lean on those communities and, that support system that they have outside of the hospital. Those are the patients that tend to do better. And we've seen patients that have large support systems not do well because they're not vulnerable enough to say, I need help, or, like I said, it's so hard for patients to say, I'm scared.
Mhm.
And so being able to, voice those concerns to their family and their friends, and really lean on the amount of support that they have, I think makes such a difference in their outcomes. And, even when medically those outcomes are poor, those patients that are able to kind of lean on their support networks, I feel like have always had a much smoother transition into, hospice or end of life care, whatever that might be. Those patients that, know that those people are going to be okay and that they're still there for them, even at that, hardest of things that they've been through. And those are the patients that really kind of have things figured out from the emotional intelligence side.
Yeah, wonderful. Thank you so much. I'm so grateful for all of that wisdom that you shared, and I know that all of our listeners will be as well. It was truly an honor to have you with us this evening. Thank you for joining us, Adam.
It was a pleasure. Thank you.
Yeah, thank you. The conversation doesn't end here. Join our community today at fucancer.health for trusted education, real community, and resources. We are here for you every step of the way.